Hello and welcome back. Hope you're enjoying your lovely afternoon tea. I'm going to take a few minutes to talk about a new resource we have around supporting the health of folks who use methamphetamine. If that slide could be put up, that would be great. So I just want to share this briefly, and you've heard some of this relevant information before, and you'll hear some in the upcoming sessions. I just want to let people know about this new brochure that we have recently created. Myself and Maureen Oscadal have worked very hard on this, and this was inspired by our colleague Philip Coffin down in San Francisco, who's an infectious disease physician, a methamphetamine treatment researcher, and a harm reductionist, and all those things really sort of come together, and you can see them reflected here. And this is available on our website, and we're printing copies of this now. And what this is really about is kind of, I think of this as like a menu of options. I think of it as you're walking down the street, you walk past a restaurant, and you see a menu up in the window, and it sort of intrigues you and draws you in to sit down and maybe learn more about the special of the day and what food they actually have. So this is really just a two-pager that starts really focused on supporting the health of folks who are using stimulants. On the first page on the left side, you can see some kind of basic motivational interviewing and engagement topics around people's use, the pros and cons of use, which is a really powerful way to engage folks. It introduces some of the issues around the health effects of stimulants, cardiovascular, neurological, and otherwise. Then gets into safer use tips, which LeiLani also really contributed to a lot here, and acknowledging that many people are using, they may continue to use, they may stop and start using, and that safer use is always going to be a really important set of tools and skills to be aware of. And then moving on to the right side, really trying to think about there are a lot of things that your healthcare provider could work with you on. As you've heard already, we don't have kind of the slam dunk or maybe the silver bullet that we think of like buprenorphine or methadone for opioid use disorder, but we have a lot of little things that can create benefit for folks. And I think if you think about sort of chipping away at this issue and sort of building up a cumulative positive effect and relationship with folks, that can be really powerful. And then at the bottom on the right, we talk about some things around reducing the stimulant use, which you've already heard about today, both around medications. And really importantly, we frame this in a very careful way, that this is about talking to your provider about medications that may help you feel better and cut back on your use. We don't want to overstate this, and also thinking about this as a tool that folks who might be care navigators or working in a harm reduction setting, we're not asking you to get into specific medications or doses or contraindications, but just like there's some medications that might help with these things, and you might want to talk with your provider about that. And then, perfect segue, we just heard about contingency management. So this is really just an opportunity to let people know in some ways, like, look at all the things we have to offer. We'd love to talk to you about this today, tomorrow, next week, next year. Like, keep coming back. We have a lot of resources and opportunities for you to work on, and we hope this can be a helpful tool. And for you all here today, thank you for being here. I'm hopeful this is something you might try out with your clients, but also share with your coworkers and your bosses and your bosses' bosses and say, hey, look at all these great things we could be doing, or our community providers could be doing. Can we also talk as a team about how we can increase access and uptake of some of these services? So hopefully that is kind of a little cheat sheet or a little handbook that you may be able to use in your work, and hopefully that ties in well to the next session, which I'm really excited to hear about. So I will stop and hand it over to Sarah, LeiLani, Maureen, and Mark.
Thank you, Caleb. Thanks for sharing the handout with everyone. And I agree. I think this dovetails very well. Everyone, welcome to the session on whole person healthcare for people who use methamphetamine. My name, again, is Maureen Oscadal. I'm a registered nurse, and I have had the pleasure and honor to work with all three of the people on our panel this afternoon, Dr. Sarah Leyde, Dr. Mark Duncan, and LeiLani Dawn. I'm going to invite them to introduce themselves individually, but before we do that, I think we have a poll that we'll start out with, and that will sort of help our panels decide or know like what direction we should be taking things. So the poll question is, what topic of these four options are you most interested in learning about today from this panel of folks who work in clinical spaces who support patients who use methamphetamine, focusing on health problems caused by meth, using harm reduction in the clinical setting, helping patients with symptoms like psychosis, paranoia, delusions, and hallucinations, and working with other healthcare workers to support patients who use methamphetamine. We would love to be able to talk about all of these things, but we will not have time. So we want to focus on the topic or maybe two that people are most interested in. So I'll give you a couple more seconds to make your choice. Okay, we should see the results on the screen shortly, and I'm actually gonna try to take a picture so that I remember in case we have time to address more than one. Okay, so it sounds like people are interested in psychosis, paranoia, delusions, and hallucinations. How do we support the patients that we see who are experiencing those things? And that was a question we were going to try to get to for sure anyway, because it came up earlier. So put that in the back pocket. I'm going to hand it over to each of the panelists to introduce themselves briefly before we get into a facilitated discussion. And I will start with Dr. Sarah Leyde.
Hey everyone, Sarah Leyde. It's an honor to be here. Thanks for the invitation. I'm an internal medicine physician and addiction medicine physician, and I practice both primary care and inpatient and outpatient addiction medicine at Harborview Medical Center and a couple of the associated clinics. I'll pass it on to LeiLani.
Thank you, Sarah. Hi, everyone. Just briefly about me. I work at ADAI as a care navigator trainer for the state opioid response. I worked in a hospital as a care navigator. I'm a person with lived experience, 20 years of methamphetamine experience, 10 years of polysubstance with opiates. Yeah, very excited to be here and talk with everyone. Mark?
Thanks, LeiLani. And hello, everybody. I'm Mark Duncan. I'm an addiction psychiatrist at the University of Washington. And I practice in the psychiatry clinic and in one of the primary care clinics. It's great to be here. So thanks for having us. And I'll turn it back over to you, Maureen.
Thank you all. So throughout the day, we've heard a lot about the importance of engagement, as how people engage people who use drugs, methamphetamine specifically. So to kick things off, I'd like to hear from each of you about how you talk to people who use methamphetamine in the clinical setting that helps you build trust and rapport and opens up conversations around supporting their health. And I will start with LeiLani.
How did I know that was coming? So I'm very, I would say, fortunate to have the lived experience aspect. And so I would approach them without judgment. I'm not there to talk them into anything or talk them out of anything. I'm just there to listen. So what I really want to learn from them is the why. I feel like the why is the most important part. And once you figure out their why, then it kind of opens up the door of how you can help support them in whatever it is they want. So that's just kind of not judgmental.
Thank you. And thank you for sharing how you sort of build that by sharing your own experience. And thank you for sharing your own experience as well, LeiLani. I really appreciate that. How about you, Sarah? How do you do this in a fast-paced primary care space?
Yeah. Well, first I just want to bring up, and I'm sure everyone in the webinar is well aware of this, but I think it's just so important. There's so much stigma in the community and healthcare especially, right? And so like from the minute someone who uses drugs or methamphetamine specifically kind of walks into our clinic, like I want them to feel welcome. So it starts with, the security team at the front door of one of my clinics, like the front desk staff, right? So it starts the moment they walk in the clinic. Are they scolded for being late or are they welcomed, you know? And can we like try to see them even for 5 minutes and do what we can? I always try to offer people like something to drink when they come in and like a snack when they come in, and like if they're cold, a blanket, if they're hot, a fan, or you know, like just attend to their basic comfort. And then I have like a spiel, which I'm not gonna like say the whole thing right now, but just like, you know, just acknowledging, right, that like in my mind, at least as a primary care doctor, like harm reduction is a worthy goal, and so is abstinence. And like, so just like LeiLani said, like we want to help you get to where you want to be, and that looks different for different people. And so just coming at it with this real like spirit of non-judgment and acceptance. Yeah, I often start by asking people like what they like about methamphetamine, what's it do for them, like recognizing that there are positive effects of stimulants, and then kind of moving on to like, what do you like less? What problems is it causing for you? What are you concerned about? I'll stop there.
Thank you. How about you, Mark?
Yeah, I think this is a great question, and I appreciate what Maureen and Sarah had already mentioned. I would completely agree. One of the things that I have found, in addition to that, and I have a little bit more of a luxury of this in a psychiatry setting, a mental health setting, is having some time. So I really like to give people the chance to kind of tell their story and hear exactly what's all been going on. Lots of times, people often don't have had really no one spend much time listening to what they're saying, or trying to understand what is going on. And so I really spend a lot of time just giving people the space to talk a lot. And I can do that because I have like maybe 50 minutes or an hour to do that, which is not always practical in other settings. But if you do have the time, maybe the conversation kind of goes in all sorts of different directions. That's not a problem, but it does really help kind of build some of the trust and engagement. And then you get into hearing some of the things about, why are they using it? How did this, where are they at with it now? And then you can kind of, ultimately I'll kind of, and what are some of the things they're dealing with that may be more of a priority? Whether that's from a housing standpoint or medical issues or the interest in counseling, things like that. And one of the questions that I always like to kind of go back to a lot is like, okay, well, we'll kind of start talking about a person's meth use. What do they want to do? What do they want to do different, if anything, around their meth use, and just kind of leave it very open-ended like that. And that really leads to the conversation about some of the things they like or not like, and where they would like to be kind of most be interested in making change. And sometimes it's not even related to meth at all. It's not like directly necessarily, but it's going to be something else, and that's fine, and you can kind of go in that direction. So I think there's that curiosity that I always have to give credit, especially to Susan Collins around. She really kind of indoctrinated me in that piece. Is really being curious about a person's life is really essential to building that engagement relationship. So that's what I would really kind of highlight.
Yeah, just to pull some things out of what all of you all are saying. So there's a time component, like making the time to get to know the person, and also these conversations are very patient directed. What is the patient's what are their goals, or what are they looking for? How can you support them versus coming in with your own provider agenda and a plan in place already and kind of setting that in motion? Like, we want it to be the other way around, and that can take time, and it may not happen all in one 15-20 minute visit. So Sarah, just to follow up with you on that just a little bit, given the constraints of primary care, how are you able to, what are your recommendations for a setting like you're in for sort of creating that space to have these conversations?
Yes, time is a precious commodity everywhere. But perhaps especially in primary care. So I definitely feel it. So my first visit with people, gosh, like one of my only goals is to help them really feel comfortable and like want to come back, right? And to do anything I can to like engage them, start to build a therapeutic alliance. I mean, I'm doing like primary care too, so if there's any like immediate health concerns, right? I start with that, and like you have to agenda set in primary care. You're not going to be able to like address everything in a 20-minute or 30-minute visit. Yeah, longer visits, Alana, yes. And sometimes I have that luxury where I work. We have half-an-hour visits. But yeah, so time is so again, just like the biggest goal for me is having them feel safe, not judged, like wanting to come back, and try to like, address their top priorities first.
Yeah,
Yeah.
that makes sense. LeiLani, did you have anything to add, having worked in the ED and a similar sort of time constraint situation?
Well, being a care navigator and a peer, when they got discharged, I would be able to say, hey, come back. And you don't have to check in, just ask for me. And I had several patients that would do that just because they would talk to me, or it would be a safe space. And same with Sarah said, offer them a bottle of water or a snack, and humanize them in the healthcare system is huge, because a lot of the times they're not. So yeah, I would just tell them to come back.
Okay. So yeah, trying to build that foundation for people to feel comfortable returning so that you can continue. And Sarah, you brought up the fact that you're in a primary care clinic and you're helping people with their health conditions. I'm curious from all of you, psychosis aside, because we will address that separately, what are the most common, and Mark, if psychosis is it, feel free to delve into it, but what are the most common health conditions you see amongst the patients you've provided care for who use methamphetamine? I know there's potentially a lot, but the main ones that are concerning to you that you see most often. And Sarah, I'll start with you.
Okay. Yes. So I think, methamphetamine can affect like many different parts of the body, but when I'm seeing someone in clinic who uses methamphetamine, I'm very focused in on a couple of different systems. So one is cardiovascular, because we see a lot of cardiovascular morbidity and mortality. So I'll just name a couple of common things I see, which are high blood pressure, heart failure, and many other cardiovascular conditions. So I'm focused on that. Psychiatric for sure, which I'm going to leave to Mark and LeiLani to talk about more. Oral health is huge, and I learned a lot from Christina Mullershin, who's on this webinar about this, actually, because like us MDs don't think a lot about oral health, which is really a shame. So I think we need to like put the mouth back in the body and like think about this more, because there are things we can do. Prescription toothpaste, fluoride varnish treatments, giving people toothbrushes, right? Like there's a lot actually that we can do. And then I'm thinking about sexual health and infectious diseases, screening for sexually transmitted infections, thinking about PrEP to prevent HIV, thinking about doxy-PEP to prevent bacterial sexually transmitted infections. I'm thinking about the skin health, like you see a lot of like picking and parasitosis, whether real or, delusional related to the psychosis. So those are kind of the big buckets, but the two like toxicities that cause the most morbidity and mortality, I think, for people who use stimulants are cardiovascular and psychiatric. So like those are the big ones that I focus in on.
Yeah, and I thank you for that. I will say on Monday at, I believe, 12 o'clock, Dr. Danny Hidano from Harborview Cardiology is going to be doing a presentation around the cardiovascular effects of methamphetamine use. So I will try to put the registration in the chat if somebody doesn't beat me to it, but for folks who are interested in that, the registration is open for that talk. And then there are some other talks that have already happened in that series around wound care and mental health care. Mark, what conditions are you seeing most frequently, and what are you doing about it?
Yeah. So as a psychiatrist, people are usually coming to me for some of the mental health issues that sometimes might be related to their meth use, but may not be. But some of the stuff that comes up quite a bit is around ADHD, so attention deficit hyperactivity disorder, and kind of the treatment for symptoms like that. And anxiety comes up a bunch, depression comes up, PTSD, of course, is there. There's a lot of trauma that this population experiences, and then psychosis does come up as well. And so it's kind of a kind of figuring out what has been there for a long time and may have been triggering for some of their meth use, or maybe what could be kind of secondary to some of the meth use, because we know meth can really cause a lot of these different symptoms at different points in a person's use history. So that can be a little bit tricky to figure out. But when you do, it is important to offer treatments for those different conditions and not necessarily wait for someone to kind of get sober or stop using. Just because what we know is that when you kind of start to do sequential treatment, one is it's going to be hard for that person to engage in the in their treatment um, if you're kind of delaying. So for instance, if they want to kind of get some, more focused treatment around their meth use, but they have ADHD, kind of waiting for some period of time for them to kind of stop may not really be all that feasible, because maybe the meth use is kind of helping them function, as we've talked about all day today, in various ways. And so treating their ADHD along the way is going to be needed. Same thing for anxiety. Maybe there's just a level of anxiousness that's keeping people from engaging because they don't have the confidence, they're worried about this or that, and they find that when they're using meth, a lot of that disappears, a lot of some self-confidence and kind of returns and all that sort of thing. And so that's you need to kind of get into that with people. So I guess the main thing that I really try to encourage providers to do is figuring out what's going on and then starting to address those symptoms and disorders, maybe at the same time or maybe even before someone's meth use changes, because it's definitely going to help facilitate that down the road when they're ready.
Yeah, and I see, Sarah, you shaking your head. I just want to confirm that you feel this, like when you're talking about sort of addressing these primary care concerns, are you doing any kind of sequential treatment, or are you also sort of thinking about things in whatever you feel like is the most important thing to treat at the time? Like how do you kind of prioritize?
Yeah, yeah, well, that was such a great explanation, Mark. I really like that framework, that framing of like how to think about mental health conditions and people who use methamphetamine. No, I totally agree. And that one thing I see a lot is oh, like their blood pressure is high. It's probably the meth. I'm gonna tell them to stop. But it doesn't work. Like, it's not that simple, right? And like maybe their blood pressure is high because of the methamphetamine. Maybe they've also developed hypertension at this point. So we have to like treat it, right? Treat it. And if people have heart failure, like they need guideline directed medical therapy. And it's okay to use beta blockers, by the way. So it's not, to me, like that practice is really rooted in stigma. Like when people come with diabetes to our clinic, we don't say, oh, you have to like not eat any sugar and lose 50 pounds, and we're not going to use insulin right now because you could do this other thing. Like no, we treat it, right? So it's yeah, very very important to just like offer the appropriate treatments.
Awesome. Thank you for sharing that. I want to bring LeiLani into this and just hear from you as a peer, as a navigator. what kinds of health conditions are you seeing patients most concerned about? What do they bring to you about the topics of their healthcare that they're most concerned about? And how do you sort of help people get connected to care in the setting that you were working with?
Wounds are a big one that I've seen a lot in the ER and on the streets. So I'll kind of talk about like in comparison to both health issues that I've seen in both settings. Wounds are a lot, whether that's like anxiety picking or, you know, that the illusion of bugs. So they would get the wounds, and then sepsis and just untreated sepsis was really big. Congestive heart failure was main thing that I've seen in the ER, along with the sepsis and the wounds, and dehydration. Like that was a really big one, not just in the summer months, which was more in the summer, but also in the winter. As we talk about in that guide, people forget to drink water. They forget to take care of their bodies, which you can't continue living without water and substance. And so that was like one of the main things that I've seen.
And how do you talk to people about these things, or when it would come up and you're talking to the clients or patients that you're seeing? How would you support them through that?
With the sepsis, I kind of would leave that to a doctor just to
Sure.
kind of determine that. But, you know, I would just validate, yeah, that's, you know, that's really scary. I understand. I can understand why you wouldn't want to come here sooner. There's a lot of stigma in the healthcare system. That's why I'm here. I'm here to walk with you through this healthcare system, and just show them that somebody actually understood. I would share my own trauma with the ER and the healthcare system in very relevant ways that kind of showed them like I really understood, and the providers that I've worked with worked alongside with me. So, you know, they kind of had that. Well, I work with a coworker who was in that position once, so this person could be my coworker someday. So they would kind of treat them a little bit better. With the dehydration, I would provide water bottles. I would try to remind them to drink water, and just really let them know the importance of staying hydrated and trying to eat. And, you know, as me and Sarah both mentioned, offering snacks, because I call it a peace offering, but really that, like, not a lot of people do that. And so when you're willing to break bread, you know, so to speak, with a patient, it means a lot to them.
Thanks. So yeah, coming alongside people and really being almost like a guide for them in a pretty scary situation, very foreign situation frequently. I mean, healthcare is a different place for sure. I think we have a few more minutes before we switch over to opening up to the audience. I want to, before we get to the topic of psychosis and how each of you sort of navigate supporting patients who are experiencing hallucinations, delusions, or psychosis, first find out from each of you what it looks like to work within your healthcare system as a team. So LeiLani, Sarah, Mark, you're all working in different specialties. How do you sort of collaborate with the team to provide care to the folks you're serving? LeiLani, I'll start with you.
Thanks. So I would usually be the first person to meet the patient. I would gather information. I would always ask permission before I gather that information, and then ask, do you mind if I share this with the nurse or the provider? And like I said, I am very open about my lived experience. And so most of the nurses and providers, they would call me to meet with the patient first, just so I can help kind of assess and kind of learn stuff that they wouldn't normally tell the providers. And then I would, with the patient's permission, go and talk to those, like the nurse or the provider, and kind of come up with something that works for the patient, with the patient, if that makes sense. Like, I would go and talk to them, we would go in, and then, yeah.
Yeah, you're like a mediator in a way.
Basically, yes. Thank
yeah,
you.
yeah.
Mediator was a way better way to put
No,
work.
yeah, yeah. Sarah, how about you? How do you work with other members of the team, whether that's with specialty care or team within primary care, however you want to interpret that question?
Sure. Well, I think just to kind of echo what LeiLani said, I think it's important to think of like who is the ideal team, right, for taking care of people who use stimulants. And so, you know, I can't say enough good things about like the peer support specialists I work with. And so I'm just like so grateful that you know, we have that expertise on our team. And so I think getting your patients connected with peer support is invaluable. And then I'll just put in a quick word about like uh you know, if you need to get someone somewhere, right? If someone has heart failure, you need to get them to a cardiologist, or someone has psychosis that you don't feel equipped to treat in primary care and you need to get them to a psychiatrist. Like, I think a lot about care navigation, because methamphetamine can cause some pretty significant cognitive dysfunction. And so cognitive impairment. And so like writing down a phone number or like putting in a referral that goes to some queue where someone's going to call them in 3 weeks, but they don't even have a phone. Like, that's not going to happen. Like, it's just never going to happen for them. And so I think we have to really think strategically about how we can get people the care they need, either like under one roof or through like care navigation, and maybe like peer support specialists can sometimes like play that role. And then I also think it's really important to like develop a network of specialists who you know are going to treat your client or patient well, because again, there is so much stigma. So like I have my favorite cardiologist. I you know, like I like put in the referral to specific people, and if they don't make the appointments, like then I'm like messaging those specialists or calling up Mark or something and being like, hey, can you help me out? Like, how can I do this in primary care? So I think it takes a lot. Like, we have to think about that. Like, it can't just like put in a referral and forget about it, because it's not going to happen.
Yeah, we can't expect patients to do all of that work. I mean, it's a hard system to navigate in the best of situations. If somebody's life is very chaotic, they don't have a phone, other stuff going on, like it's not an easy system to navigate at all. So yeah, totally. Making sure that we're working hard to make it easier for people to be successful. Mark, how do you work with teams? I know that you do a lot of work supporting other programs, providing guidance. Who are your teammates, and how are you kind of collaborating?
Yeah, you know, I think really with any kind of medical condition, I think having a team is essential, but especially with meth use, due to what Sarah and LeiLani was saying, just because it can affect so many different things. And sometimes life can be pretty chaotic. And so you may not, maybe someone's coming to see me, and a big part of the conversation is due to a skin issue or an infection or something else that's not even psych related. So, I really try to make an effort to be a little bit of that bridge, even though maybe it's like not my scope to talk about their skin or their heart issue or medical stuff. But if that's what's coming up, I need to make sure that that person's other provider or team member knows what's going on. So in our system, maybe that's just me like sending a specific chat to that person or sending a message to say like, hey, I saw so and so. This is what we talked about. There's really concern. You don't have an appointment on the list. Can you get this going in some way? And so I think really using your team, thinking like who all is involved and bringing them into the picture, I think is essential. And so you have that develop that network of specialists that Sarah mentioned, I think is really key. And then reaching out, and being proactive. So for instance, at some of my sites, that often might be outside of the typical referral order. Someone is sending me a text message on my phone saying, hey, I got this patient I want you to see. Can you get him into your schedule? And then, I look them up and I get them, say like, oh yeah, okay, let's get this person in. I can get them in next week or something, or my next appointment. So really not only using your team, but kind of being an advocate for your patients is going to be useful. Even for the, an advocacy, that's like, even for people that are all, really trying to be very helpful, just letting them know about what can be done. Not even saying anything about the advocacy you need to do for people, where two providers that may not be very knowledgeable or understand around stigma or what's going on with meth. I mean, that of course needs to happen. But advocate for your patient, to your teammates, in the moment, so you all can kind of help. Trying to do anything on your own just by yourself, it's very hard to do, and that for any kind of ongoing issue. But team really makes it sustainable. And so I think that that is something that sometimes as providers, we think, we're in the moment. We don't maybe not always think about who else is around that can help. That's a very hard spot to be. So I think that team piece is really essential.
Thank you. I think you sort of, there's a question in the Q&A and then a question I was going to ask, and you brought up advocacy, patient advocacy. I'm going to try to meld these three things together. So what, my original question was, what is one thing that you want teams or the audience to take away from this discussion? How can we sort of motivate healthcare providers and healthcare teams to be doing this work? Christina in the chat asked, how do you all have suggestions for how non-clinical folks can start the conversation with medical staff to encourage them to expand the care they're offering to people who use methamphetamine? For example, doing those workups to check for heart disease and not assuming that it's for just methamphetamine and they just need to stop using. What are some takeaways or recommendations you all have for bringing more healthcare teams on board to be motivated to do this work? And I'll let anyone take that question.
I'll jump in. So I can't take credit for this idea. Eddie Goldstein was really the one who kind of talked about it this way with me. I don't know if he's on this call or not, but he kind of really talked about using the same tactic, meeting people where they're at. So meeting other providers where they're at, and coming alongside and talking about what that could look like, why you would want to do this, and then developing that relationship and expanding the scope over time. It was really kind of a very similar approach that he was taking with the patients that were using various drugs that he was working with. And I thought that was completely accurate. You can come in like, I can come in and kind of give my little talk about this or that. And, they're going to say, okay, that's nice, Mark, you're an addiction psychiatrist. Of course you would do that sort of thing because that's your specialty. But it's in those relationships over time that you're going to need to invest in, that's going to help bring people along, and show them, make the connection where talk about, okay, well, maybe some of this is meth, but we have a lot ADHD we know puts people at risk for using meth, and so maybe it's not, and maybe we need to treat their their ADHD symptoms while you're working with them on various things. So, and anyway, so it's kind of building those relationships with other providers. And as a non-prescribed, if you're not a provider, to get to that question, LeiLani or Maureen, I will acknowledge the power differential is very challenging. It's unfortunate, but it is. I recognize that. So maybe that doesn't mean you still can't develop a relationship, but I think also if you're able to kind of bring in other kind of peers, to help with those providers from the outside and just have some conversations, which I've definitely been asked to do at various times, that can be pretty helpful. But the power differential makes it challenging.
Yeah, absolutely. Sarah or LeiLani, do you have anything you'd like to add to that?
Sure. Yeah. Well, Christina, thanks for the excellent question. I think it's tough. I also want to acknowledge, like, obviously there's a lot of stigma, and there's also um like a real lack of knowledge about this among like generalists. Like we're all here like learning about methamphetamine because we're really interested in it, right? But when I was in med school, which, you know, whatever, like 10, 15 years ago, like I read like one paragraph about methamphetamine. Like that was the extent of my education. Like I'm not kidding. Like seriously. And so it's, and then like a little bit more in residency and a lot more in addiction fellowship. But a lot of the providers, especially in primary care, where there's just this like litany of different things. Oh, I had so much pressure to like offer the mammogram, do the pap smear, do this, do this, do this, do this, refill all the meds. It's like sometimes like the providers also just don't realize that like they should be doing these things. So I actually love the idea of like printing out that flyer that was developed and having patients like having like people at you know like peers or case managers, whoever the patient is working with, like think about their agenda for the visit ahead of time. Okay, like what are the 2 or 3 most important things I want to cover today? And even using that little checklist and being like, I'm worried about sexually transmitted infections. Let me like circle that and bring that to my doctor and be like, hey, I use methamphetamine. I'm not planning on stopping, but I want to take care of my body. Can we like do this and this today and work on the other stuff later? Like empowering the patient to like bring that agenda forward, I think would be helpful.
I love that. Thank you. That's a great suggestion for the handout that we've been developing. So just thank you for that. I think we should switch now over to psychosis. I think this is probably deserves a much more time, and I want to acknowledge that. This is a topic that I think Mark presented on for about an hour at a conference recently. So I don't expect this panel to have the ability to answer all of the questions that people might have on this topic, but we know that people who use methamphetamine can experience delusions and feelings of persecution and hallucinations acutely. They can have, they can also experience it long term. Mark, if you want to briefly sort of give us a brief explanation or sort of background on that. And then I want to invite all of you to sort of talk about how, when you're caring for a patient who's having acute symptoms, how you sort of help people feel safer in the space that they're in and help people get their needs met. So Mark, if you could do your best to give a Cliff's Notes on the topic, that would be great.
All right, thanks. Sure. Okay, so very quick, methamphetamine can increase levels of dopamine in the brain. Dopamine can cause psychotic symptoms. And when we talk about psychosis, that could be auditory hallucinations or visual hallucinations or delusions. And the delusion could be, something that is, something that's it's a fixed, by definition, it's a fixed false belief. So something that's not real, but they think that's very real, and it's hard to separate. So that could be something in paranoia. It could be the parasites we were talking about. It could be very elaborate. Sometimes, I've had delusions anywhere from people thinking something's been implanted in the brain to, thinking that they're being chased down by some nefarious person, and so forth. In any case, that's kind of what it is. And we often can see this anywhere between like 1.5 to 5 years after a person is using meth. And it can, it doesn't happen to everybody. There's ranges from like 1/4 to 1/2 people who have meth use disorder will experience psychosis. And then oftentimes, most people, that resolves within a few days. And so just to be clear, it can easily last for several days, but that doesn't mean it's going to stick around forever. That said, there are some people where it will be permanent. Like it can actually develop into a permanent set of symptoms for for a life over the course of a lifetime. So basically, when you think about if someone is having some psychotic symptoms and they're in the visit, there's kind of 3 different talking skills that it's worthwhile doing. One is assessing for safety. We when people are in a psychotic state, they're going to be taking often risks that they normally would not take, or do things they normally would not do, or maybe not eat or drink or do all sorts of different things. And so really figuring out, are anything from suicidality to thoughts of hurting other people to just not taking care of themselves, and saying, hey, are you still, maybe are you still able to get some food in you, or still able to get some water? Do you have a place to go? Those sorts of things. So there's that. If you are in a conversation and the conversation kind of goes in a direction around, the maybe some conspiracy at the clinic that's against them, and different people are starting to get involved, oftentimes you want to validate that is obviously very scary. It makes sense why you'd be worried, and you want to stay safe. So you're validating that experience because it is very scary. And then you can redirect. And let me ask you how you're doing with your medicines for your skin infection or whatever it happens to be. So I wouldn't spend a lot of time getting into that delusion, because there's not going to be an end to it. It'll just keep going and going and going. So validate the experience and redirect. And then the other thing you can often talk about is teach a skill. So sometimes, just, teaching someone, to kind of recognize those concerning thoughts. And is there a way that they can do to distract themselves? What's been useful in the past? For some people, maybe it's a song, maybe it's, I don't know, going for a walk, or maybe it's watching a video, but there's other things, or sometimes it's a mantra, all sorts of different things. Maybe it's a prayer, if that's part of it, if they have a spiritual background. So teaching a skill can be helpful. And then from a med side, I like to keep it pretty simple. If people are having psychotic symptoms, prescribe an antipsychotic, and see them back soon, like within maybe within a week, within 5 days, or at least give them a call. Even if it is going to be like just a week of symptoms, you don't know. So I will, it makes sense to me to prescribe an antipsychotic, check in with them, and then you can taper that off later, or in some cases discontinue. So anyway, that's kind of my quick synopsis, and I will pass it over to back to Maureen.
LeiLani, did you have experiences, or have you had experiences supporting people who are having acute symptoms of psychosis, and how do you support folks in those situations?
I would, try to validate them as much as I could. Just because you don't want to escalate them. So just try to validate and be like, yeah, that must be scary. And then just, if they want to share details, and just kind of listen, that's about all a care navigator and peer can do, is just be there to listen to them. So
yeah, but that's huge though. That's not nothing. Being there to listen is often not something that is, doctors and nurses aren't doing that, especially in the ED. They don't have time to sit down. So that's a huge thing that can help someone feel safe, which is so critical in those situations. I think is just ensuring that the person themselves feels safe. Sarah, how about you? How are you supporting patients who you see who maybe report that they've experienced symptoms when they're using methamphetamine, or they think it's related to their methamphetamine use, and or acutely symptomatic in clinic? How are you working with folks?
Yeah, I mean, totally agree with everything Mark and LeiLani have put forth so far. I think de-escalation can be really, like, just general de-escalation techniques can be really helpful. And if someone's in a crowded, busy lobby and there's a bunch of security guards around, that can just make things a lot worse. So can you get someone to a quiet, dimly lit room, to grab them some water or a fan if they're hot, right? Like, can we just bring down the temperature a little bit? That helps. I will also just say, I think I just want to empower the primary care doctors out there to prescribe antipsychotics. I mean, if we had 1,000 more amazing psychiatrists like Dr. Duncan, we wouldn't have to, right? And that's the gold standard. And I would love all my patients to see psychiatrists, but that is not the case. And I think we can't let perfection be the enemy of good. And sometimes it takes prescribing an antipsychotic to get someone to a psychiatrist, ironically. So I would just say, like have a couple of like, know about olanzapine and risperidone at the least maybe, and just like the starting doses and like I feel empowered to do that. I also think like the as needed antipsychotic discussion is really interesting after that olanzapine support pack study came out from Philip Coffin's group, and would love to hear what Mark thinks about that if we have time. But
Mark, do you have any input that you'd like to share on that piece?
Well, thanks, Sarah, for the endorsement around personally, but very kind, but also around prescribing antipsychotics. And if there is ever a question around prescribing antipsychotics or any psych meds, there is a 24 hours a day, 7 days a week, 365 days a year hotline you can call to talk to one of the UW psychiatrists. I man that on Monday afternoons and then after hours sometimes. And you can call it literally 24 hours a day. So please use that resource. If there's a question, you'll get connected with someone right away. So yeah, I think that if psychosis symptoms have been part of the picture, and especially if they have active psychosis in your clinic, then prescribing an antipsychotic makes a lot of sense. And if that is, and again, I think just to be very clear, if that has been part of the picture, so if there is some history there, the use of meds like olanzapine, which is the one that was used in the study that Sarah had referenced, is a very good option. And I think it makes a lot of sense to use that. Right now, I'm in the position of like, I want psychosis and psychotic symptoms to be part of that if I'm prescribing it, sort of thing. But I think it's it's a little bit of a shift from where I have been, and I think it's a worthwhile thing to consider for sure.
Thank you. Thanks for providing your expertise on that, Mark. Appreciate it. We are coming close to the end of time, and I want to pose a question to all of you just as we wrap up. Thank you for sharing that in the chat, Sarah. Before I say what I was about to say, the link in the chat for the START clinic, I think the guidance around the START clinic, which is at Boston Medical Center, is really, really helpful. You do have to create a login in order to access those resources, but it's free, and the resources through the Graken Addiction Training Center are all really valuable. So if people are interested in how a clinic has sort of created a space that is low stimulation, that is welcoming to people who use methamphetamine, all of their stuff is online, which is really wonderful. So as we're wrapping up, I want to invite each of you to just share your words of wisdom. We just sort of touched on this a little bit, but what would you each like healthcare teams to take away from this discussion today? What would you like people to have to feel like they can do this, or that like what's something that you'd like people to remember from today's discussion as a panel? And LeiLani, I'll start with you.
Oh, I was gonna unmute myself and start anyway. To walk alongside the patient, let them be involved in their care, their decisions in a non-judgmental kind of way. Just walk alongside them and help advocate for them.
Thank you. Sarah?
I think that was really well said, LeiLani. I mean, I think I think the big thing for like the doctors out there, and I guess everyone probably is like, you need to like earn the trust of of people you're working with, just with the backdrop of like so much stigma, and probably terrible experiences in the healthcare system in the past. And so I always think of like, okay, it's actually that's my job, is to like earn their trust, right? And so like, how can you do that? And really like intentionally engaging the patient before you like dive in and tell them that their blood pressure is terrible, right? It's important to do that first.
Yeah. Recognizing that you're entering at a point where people probably have already had multiple bad experiences with the system, and that regardless of what your attitude is, like you're rebuilding that trust from past experiences. Yeah, I appreciate that. How about you, Mark?
Yeah, I completely agree with what Sarah and LeiLani have said. That is first and foremost. I think the other thing is that providers need to remember there are things you can do. Lots of times we all, we get into this state of mind. It's like, oh, there's nothing you can do for meth. It's hopeless, blah blah blah. But that's not true. I mean, earlier today we had there was a great session with people with lived experience. LeiLani was talking about hers. There are all sorts of different ways you can engage with people and help them and with where they want to go. So don't get discouraged. Just people and things can and will get better. So just try to do that. And again, I think that's where that team piece comes in. Working with the team is so essential to help remind ourselves, like when we get down on things. So that's all I was going to say.
Thank you. That was a wonderful wrap up, Mark. I don't think I could say it any better. And we are at time. So thank you, Sarah. Thank you, Mark. Thank you, LeiLani. It's wonderful to work with you all today and in the real world. And hand it back to Caleb.